Okay, great. All right. Well, thank you everyone for joining us today. I'm pretty excited about this. So hopefully we're going to get through these objectives. What I'm hoping to do is just share a little bit about the effects of medications on the environment and then some ideas about things we can all do to reduce these impacts. The strategies are mostly aimed at prescribers, but I hope others in the audience will also find them interesting. And there's references for pretty much everything at the end of the presentation. So unless you've been living under a rock for the past 20 or 30 years, you've heard about climate change and other environmental challenges that we're facing. So I'm not going to talk about that much. The the environment is now a mainstream topic, and a lot of people are thinking about what can I do? How can I help? Especially in healthcare, because health is our mandate, and we know that this is affecting people's health. And that's great because in healthcare, we're part of the problem, contributing about 5% of the total greenhouse gas emissions in Canada and globally. But healthcare is important. We can't just stop providing care. So how do we reduce this impact? Well, fortunately, it isn't as hard as it sounds because when we practice environmentally sustainable healthcare, including sustainable prescribing, it often means working more efficiently with less waste. And it turns out that this is also better for patients and it can save us all time and money. It's really a win-win-win. The first step in doing this is to better understand what part of our healthcare system actually has the greatest impact. For many of us, when we think about environmental action, we typically think about things like retrofitting buildings and making hospitals more efficient or bringing in recycling programs. We think about the garbage we see, the big piles outside the operating rooms. And all these things are really important. But it turns out if you look at the carbon emissions from the healthcare system, about 80% of them come from outside the walls of our facilities, upstream in the supply chain, where they produce all the materials that we use to provide clinical care. So this isn't just an operations problem. We as providers have an important role to play in reducing the medications and the investigations we order, and the procedures we do are major drivers of the problem. So it's clear that no matter how creative we get, we're not going to be able to recycle our way out of this mess. We really need a fundamental shift in how we think about environmental action in healthcare. In primary care, the main target is obvious because as you see here, 61% of our greenhouse gas impact comes from the pharmaceuticals we prescribe, which includes 13% from meter dose inhalers alone. So if you're wondering where to start to reduce your own environmental impact at work, you're in the right place. This is the place. But how does this really work? How can a simple pill have such a big environmental impact? We need to think about the total life cycle of that little pill and its packaging. First, the raw materials need to be extracted, the wood, the oil, the minerals. Then they need to be processed, manufactured, packaged, finally shipped to a distributor, then to a pharmacy where it's often repackaged, possibly injected using more supplies. And then ultimately, it all needs to be disposed of. And if you really think about all the energy and resources needed at every step of this process, it starts to make sense that even though we don't see any of this, it's invisible, it still has a huge impact. Many of you will have already heard now about the problem with meter dose inhalers, which have an aerosol propellant, a hydrofluorocarbon, that's a greenhouse gas more than 3,000 times more potent than CO2. One blue puffer causes the same climate impact as driving 290 kilometers. Fortunately, there are equally effective alternatives, dry powder inhalers and others that have only a fraction of that impact. Anesthetic gases are another problem. They're another powerful greenhouse gas, especially one called desflurane. And over 95% of the gases administered to patients actually are vented directly out into the environment. Some of them stay there for years. Using the car comparison again, using desflurane for a 1-hour anesthetic is the same as driving 370 kilometers. And many hospitals are phasing out use of especially desflurane, but also moving towards using more intravenous anesthesia when possible. Along with the greenhouse gas effects, pharmaceuticals also have other direct polluting impacts when they're released into the environment from manufacturing or from excretion and disposal from consumers. More than 600 different medicines can be found in water and soil, and not much is known about their effects on natural world and ultimately on human health. We do know that when we take a medicine, only some of it's metabolized. So anywhere from about 30 to 100% of the product is excreted. Unfortunately, most sewage treatment facilities aren't designed to remove medications. So most of it then goes directly into the environment, where it's been shown to have effects on aquatic plants and animals, like studies showing how estrogen affects survival and breeding in some types of fish. And an even bigger problem may be the effects of the much more concentrated industrial effluents from pharmaceutical manufacturers. Some of the worst examples have been recorded in other countries. One of the most notorious is a study where they found that the daily discharge of ciprofloxacin from one plant was 44 kilograms per day. That's 88,000 doses. Even in Canada, a study done in Ontario in 2019 found that manufacturers discharge effluent for many different medications directly into the sewage system, which, as I said, doesn't tend to remove the medication. So basically, it's just going straight into the waterways as well. Even in Canada, there's not much regulation or monitoring of this activity. Other studies in Canada have found trace amounts of large varieties of pharmaceutical agents, even in treated drinking water, sometimes even in very rural and remote communities. And it's not always clear how it gets there. The effects of this on humans isn't very well studied. One report estimated that even drinking 2 liters a day for 70 years, pretty much your whole life, the body would only accumulate about 1% of a normal daily dose. So it's very low concentrations that might accumulate, but some experts are still concerned that there might be unintended consequences for more vulnerable populations, for example, infants drinking formula made with this tap water. The one exception to this lack of data is when it comes to antibiotics. Antimicrobial resistance is widely documented and linked to all these different sources. And as we know, antimicrobial resistance is a huge and growing threat. It doesn't matter where it comes from, unfortunately. Once resistance develops anywhere in the world, it can become a global problem for all of us. Unfortunately, as clinicians, we don't have much control over any of this, the agricultural or the industrial antibiotics, but we do have a lot of control over what we do in our very own practices. So let's get to the good stuff here. What can we do? What can we do in our own practices this afternoon when we go back to work? Even though every prescription has only a small effect, the cumulative impact of 600 million prescriptions per year in Canada is enormous. And here's a great place to start. According to this study and many others, about 30% of what we do, tests and treatments, isn't actually necessary. It doesn't benefit patients at all. And it causes harm. It wastes time. It wastes money. It leads us to be the generators of our own treadmill. Clearly, one of the best ways to reduce our prescribing footprint is by just eliminating these unnecessary prescriptions. There are a few different ways to do this, and a lot of them sound sort of obvious on the surface, like Medicine 101. But we'll look at each one of these items more carefully and see how using an environmental lens can help nudge us towards higher value patient care with lower environmental impacts. Avoiding overdiagnosis is a big one because, of course, overdiagnosis often leads to overtreatment. Overdiagnosis happens a lot more often than you'd think. It's when we make a diagnosis that doesn't lead to any health benefits. And of course, as I said, this can often lead to overtreatment. Medicalizing normal human experience is a common cause. It's a bit of a slippery slope that I often find myself on because we're all hardwired to help. And so when somebody comes in with a problem, say, it's easy to jump to a prescription, even if the patient doesn't quite meet the criteria for diagnoses. An example is asthma. 30% of people who think they have asthma don't actually have it when you test them, but many of them are on puffers anyway, often started for things like that post-viral cough, which apparently puffers don't work for anyway. Overscreening asymptomatic people can also lead to overtreatment, since every test has about a 5% chance of falling outside that normal range. And then there's the insidious diagnostic creep, the sneaky little shifting in the guidelines with lower and lower thresholds for diagnoses and pre-diseases like pre-hyperglycemia and pre-dementia, pre-hypertension. These labels make people think they're sick, and both patients and providers are more inclined to think we should be doing something about it, like giving them some drugs. Unfortunately, these guidelines are sometimes influenced by groups with special interests, and there's often no evidence that patients will benefit from these pre-diagnoses. The next thing, again, seems obvious. Non-pharmacologic options is the first line of every management guideline I've ever read. As clinicians with the power to prescribe, however, we often skim over these because medications are one of our main tools in our toolkit. And when you have a hammer, as they say, everything starts to look like a nail. But in primary care, especially, where the acuity and severity of illness is low and many conditions are self-limited, it's often okay to just do nothing while the problem takes care of itself. This is known as deliberate clinical inertia. I like that. In other cases, we really know that what the patient needs is CBT or smoking cessation counseling or nutrition advice, but we may not have the skills or the time to do this ourselves. And that's okay. We can't all do everything, but it's important to know who can and refer, knowing you'll actually be helping patients more than by giving them a prescription, because you're giving them access to long-term strategies and tools that will last them a lifetime. It doesn't really make sense to try to treat a social problem with a medical solution anyway. This teamwork approach is thought to be one of the keys to both excellent patient care and a sustainable healthcare system. And if you really want to write something, some kind of prescription, you can also collect some other tools to write prescriptions that are for things other than medications. Recommending a plant-rich diet or active transport or a green prescription like the Parks Prescription Program for nature can have direct environmental benefits along with avoiding an unnecessary medication. The viral prescription you see an example of here, that's basically a prescription you can give people instead of giving them an antibiotic when they come in with their cold. And it explains why you're not giving them an antibiotic, and also gives them some tips and strategies on other things they can do to start feeling better. Some of the most interesting things that I've learned while doing this work is about patients and how our relationship with them affects our prescribing practices. A number of different studies have found that about 50% of patients don't take their medications like they're supposed to, and 20 to 30% don't take them at all. We assume this is due to poor understanding or cost or side effects, but sometimes patients just don't want those pills, and giving patients medications they don't want just doesn't make sense. And of course, it increases your prescribing footprint. Healthcare may be the one field where we would save money and time and reduce risk by giving people what they actually want. Of course, non-adherence can also be a problem of underuse of appropriate medication, and that is a problem too. Either way, the secret to improving all of this is better communication. And one of the best ways to do this communication is using shared decision-making tools that help us explain the pros and cons of different options so patients can make a really well-informed decision. We do this with surgery, but less so with medications. In one study, 50% of patients didn't feel they were involved in their care decisions, and many didn't even realize there were options. And there are always options. Clinical practice guidelines often make it seem like there's just one right answer, but they're just suggestions, not rules, and they always need to be interpreted for each individual patient. In one study, shared decision-making led to reduction in overuse of antibiotics for respiratory infections by 48%. Other studies have shown that 20% of elective procedures would be unwanted if patients had access to understandable, relevant clinical information. And on average, in case you're wondering who has time to do this, shared decision-making usually takes about an extra 2.5 minutes in a visit. One of my favorite shared decision-making tools is the CVD risk calculator created by BC's very own James McCormack. Patients love this, and it really helps them see the absolute benefits and risks of treatments and lifestyle changes. And there's so many similar tools available for different conditions. Showing patients the number needed to treat or the number needed to harm is often an eye-opening experience for patients and practitioners as well. We tend to overestimate the value of medications we prescribe. Most people have no idea that statins, for example, postpone death by only about 10 to 14 days on average. Asking what matters to you is another little important thing that we can do that typically takes only about 90 seconds. And in the long run, it can improve the efficiency by avoiding unwanted care, complications of treatment, and requirement for ongoing monitoring. One study found that all these benefits, um, providers learned something new about their patients. They changed something in their practice as a result and had better relationships with patients. We're all just a simple matter of asking this very basic question. Having these conversations, particularly when patients are experiencing serious illness or when they're near the end of life, can allow us to safely reduce a patient's pill burden and improve their quality of life. The most important part of this is making space and creating an environment where patients actually feel you're willing to listen to their opinion and recognize that they are the experts in what they want or how they feel and what they believe. And we really need to trust them on that. We need to keep reminding ourselves and our patients that medicines aren't actually as effective as we tend to think. As a therapeutics initiative audience, you're probably all very familiar with these, so I won't go into too much detail here, but refer you to the excellent therapeutics letters that Erin was talking about. Antibiotics, again, are such important targets because of the multiple ways that they can harm the environment. So we really need to keep up on the evidence because the list of indications for antibiotics is growing shorter every year. And so is the recommended duration of antibiotic treatment. In the past, we used to be told longer is better, make sure you finish your antibiotics. But now we're learning that, in fact, these shorter courses are just as effective and actually decrease antimicrobial resistance. The last point is about de-prescribing. We get a lot of training on prescribing, but very little on how to stop medications. But fortunately, we have a lot of opportunities. Every time we do a refill, we can have a look at that list and think about, which of these medicines maybe we don't even know why patients taking them anymore. Pharmacists can also do medication reviews and flag potential problems. And there are great resources out there through the Canadian De-prescribing Network in particular. They've got great patient handouts and de-prescribing algorithms. One study showed that just giving patients a handout about the risks of sedatives reduced prescribing by 27%, which kind of makes you think that if patients actually knew the harms of some of the medications that they were on, they might not want to be on them. So, of course, there's a lot of times when medications are required. We've talked a lot about how not to prescribe, but often medicines are appropriate, of course. And appropriate use of medication can actually reduce environmental impacts because they help avoid more advanced illness and complications in some cases, which would require even more resource-intensive care, such as surgery or hospitalization. When medications are indicated, there's a few things you can consider to reduce the impact of your prescribing. Switching from more to less harmful forms of medication, like the meter-dose inhalers that were mentioned earlier. Thinking about using tablets or capsules instead of liquids, especially parenteral forms. Giving 1-week trials or deferred prescriptions for antibiotics and other things. The radical idea of redispensing is already being done in some places and could save a lot of waste and money. There's an example in the Lower Mainland where they calculated there's about 500,000 unused doses of medication per year. And if they sort of reclaimed and reused them, they would save about $350,000 a year, which is pretty good. Minimizing packaging whenever we can, for example, using reusable, pill packs instead of the disposable blister packs. And then thinking about using longer acting forms of everything. IUDs instead of pills are a great example. That can also reduce workload for prescribers and pharmacists. Imagine one prescription every 5 to 10 years instead of, a package of pills every month. Some practitioners might struggle with the perception that we're withholding care when we do this sort of thing. Sometimes it's difficult to know how to respond when patients present with requests for unnecessary treatments like antibiotics for colds. Because our focus has always been on the individual patient and we talk about patient-centered care, it's easy to forget sometimes that above all, we've been given this right to prescribe, and it's a serious responsibility. We have a duty to do the right thing, balancing all the ethical principles while considering both the individual patient and the larger population in both the short and the long term. And when we add environmental justice and intergenerational justice in there, scales are tipped in favor of careful resource stewardship in pretty much every case. Another driver of overtreatment is known to be what's referred to as defensive medicine, a fear that something will go wrong if we don't prescribe. But according to the CMPA handbook, more people get in trouble because of adverse effects of treatment, particularly if that treatment wasn't required in the first place, than from not prescribing, especially when your decisions are informed by evidence, which is, of course, what we're advocating here. And most importantly, communication is always your best defense. And of course, it's also best for patients. So there's a few important myths we need to debunk to help reduce our impact that we can educate our patients about. Our patients, pharmacies, and hospitals could save a lot of money and waste if we realized that expiry dates are just arbitrarily assigned by pharmaceutical companies to increase profits, not to protect patients, and they're certainly not based on any kind of evidence. This image is from a small community hospital, medications collected from just a few weeks. Oh, I was one slide behind, sorry. So myth number 2, vitamins and supplements are effective. Again, there's limited data and evidence on effectiveness or safety of most vitamins and supplements. It's a huge industry, and so obviously, even though I don't have data on the environmental impact, it's clear there is a significant impact from this industry, and it's largely unregulated. Myth number 3, flush medications disappear as if by magic. Of course they don't. A lot of people don't know this, or at least they don't think about it when they flush. 40% of people don't dispose of their medicines properly, and this is another huge opportunity for education with our patients. So just to summarize some of the big easy wins, things that you can take home and, like I said, use this afternoon if you want. Switching from meter dose inhalers, I think I've already mentioned that a few times, and it's because it's really important. That's probably your biggest, easiest win. Trying to pause before pulling out the prescription pad for antidepressants as first line for mild to moderate depression. Writing prescriptions for things other than medication, using those shared decision-making tools, and asking your patients what they really want. Do they actually even want a prescription? Sometimes we assume they do, but they don't. Avoiding unnecessary antibiotics and shortening those durations, again, a really, really important target for our efforts. Think about offering an IUD to every patient who comes in for birth control pill refill. And remember about the importance of referring to our skilled team members. So you'll notice a lot of these recommendations are similar to ones you've heard from other organizations, like choosing wisely. And they're things that are good for patient care and good for our system. But thinking about the environmental benefits of these same actions just gives us one more important reason to make these changes. And there's some resources for other organizations doing similar work, choosing wisely, in the rest of the presentation if you get a copy of it later on. So why does this all matter to me? Oh, sorry, I keep forgetting to advance. There it is. That's why it matters. It's because of these guys. These are my kids and all the other people in their generation. By being careful stewards of the finite resources in our system now, we can avoid the moral distress that many of us felt during the pandemic, not being able to provide care to our patients. We've all got a chance to do something now to make sure that we have the resources so we can continue to provide care that's needed to the people who need it most. This will leave our kids with a more sustainable system on a more sustainable planet. So this is a little bit that I'm doing for my kids. I hope you can all take something away that you can use too. Thanks for listening.
Ilona, thank you so much. That was very, very informative, and I certainly feel excited and motivated to try to have an impact, and you've given some really good practical recommendations.
Great.
Thank you.
The job's
Again.
done.
No, not quite.
Oh.
You have to answer questions, yeah. Maybe I'll give you a chance to have a sip of water, and I'll just remind the audience that if you registered, you'll get an email evaluation with some questions that we'd like you to answer, and then once you complete and send that back, we'll provide you with your continuing education credits. And just a quick reminder about our portrait program for prescribers in BC. So if you're interested in learning about your prescribing patterns for common medical conditions and problematic drugs in BC primary care, then sign up for Portrait. We'll show you confidentially your prescribing patterns and compare that to those of your colleagues and give you some summaries of the evidence to help you optimize your prescribing to better align with evidence. So check that out. If you have any questions about that, you can always contact me, aaron.tijani@ubc.ca. So Ilona, a bunch of questions. And for everyone in the audience, we'll try to get through as many as possible. And then whatever's left, we'll see how much volume there is and potentially try to get some of those answered and posted on the website. So let's get to them. The first one was a comment about Ontario and detecting high levels of metformin in the water systems there. And so I'm not sure if I've never read that study, but if whoever submitted the comment, if they want to post the link in the chat, that'd be great. I'll start off with my question. Do we know what proportion of prescriptions are filled in the community that are never used or started for a few days and stopped and end up in the garbage? Do you know how big a problem that is?
No, I don't know. I just have those two stats about, people don't take them, but I don't know if they don't even fill the prescriptions or some of them fill them and then don't take them. I don't actually know.
Okay. I'm just wondering if a campaign with community pharmacies, like to encourage or something about encouraging people that if you don't end up using them, bring them back for disposal. There's another comment in the chat about some community pharmacies were reluctant at the beginning of COVID, taking anything back because of the risk of contamination. We went through a similar concern in hospital, and our infection control group within the hospital system said that's no longer a concern. So are you aware of, or do you have any ideas for community pharmacies in terms of medication returns?
Yeah, I think they're all mandated to take stuff back, and I think they all have a process for disposing of these medications. I've talked to a few pharmacists, and some have said that they, if they're not that busy, they'll actually try to take stuff out of the bottle. But of course, then you have to block out the label. So pretty labor intensive to actually even do that. So then if you're incinerating, the medication in the bottle, that's obviously also not great, but it's still preferable, I believe, to just flushing them down the toilet. Yeah. So
yeah, it's interesting. We're going through the same thoughts in the hospital system, and it feels like when you have a busy community pharmacy or a busy hospital pharmacy, and then you say, hey, why don't you add something to your list, properly disposing of these medications, and they're already short-staffed, it doesn't seem right. I'm wondering if we need to start thinking of alternative solutions where you use resources outside of those dispensaries to come in and do the work for them, and that they can continue to do what they're good at, which is dealing with the distribution of medications and counseling patients, and then have people that have a different skill set that come in and take the waste away and deal with it in a proper way.
Yeah. Well, in your example, I think it might be cost effective even to do that, because obviously wasting all that. I'm not sure about the return medications, but like you were talking about in the hospital, where you can actually reuse the medicines if it's been, you're certain it's safe. I mean, that makes sense. The other thing I was going to say, though, is, I think that upstream giving a patient that medication that, they didn't want in the first place, is one thing we can do right now, or at least try to do.
Sure. Yeah. We have a question. There's apparently a Swedish database, janisinfo.se. It's a tool that you can look up the environmental impacts of medications. Are you familiar with other resources that outline how bad any particular medication is?
No, and I guess I'm not sure which type of environmental impacts they're talking about. There haven't been life cycle analyses done on very many, like that, the total sort of carbon footprint analyses done on very many medications that I'm aware of.
Okay. There's a question here. Is there pressure from pharmaceutical companies on prescribers to prescribe more? Is the pharmaceutical industry a barrier, a help, or neutral in the goals for providing high value care? that has that reduces the environmental impact. So I guess, do you know if they're doing anything to help or not really?
Well, I think, at the industrial, like the manufacturing level, it was interesting to read into the literature that the pharmaceutical companies are actually doing a lot. I think their motivation may be in part cost saving, but unfortunately, they're not releasing a lot of the data because I don't think they want to sort of compare, one company against another. But they have also done studies looking at, how the different pharmaceutical companies compare in terms of their overall environmental impact. But
Okay,
so they're trying. Yeah.
that's good. Let's see. Do you think that the lack of access to primary care family doctors exacerbates this problem due to increased expectations, pressures to prescribe that might occur in one-time visits, for example?
Yeah, I'm afraid I think it might, and it's not to be critical at all. So I have a longitudinal family practice, but I sort of sympathize with physicians who have to practice in a situation where they aren't sure that the patient will ever come back. They don't know the patients well. It makes it a lot harder, maybe to make some of these decisions compared to when you know your patients and they know that they can come back anytime if you decided not to give them that antibiotic, but they get sicker than they. So it is harder, but I think it does seem to have an effect.
Okay. Another question, how can allied health professionals like OT, PT, etc., facilitate reducing the pharmaceutical footprint of medications? It is important to know how clients' patients understand their medications and whether they understand how they can be a part of the process in reducing this footprint. So any advice or suggestions for allied health?
Well, I just think all the great allied health professionals just keep doing their job because if you can keep patients managing their pain with physical therapy or functioning better with OT, that I think that's the most important thing. But of course, I think we've all got a big job to do in educating patients about medications too. That's job number 2.
Okay, great. A couple, you mentioned MDIs, meter dose inhalers, and potentially using fewer meter dose inhalers. There's a comment here that terbutaline under the brand name Bricanyl is a dry powder inhaler rescue beta agonist, which is a good option. And I know in the hospital we're looking at the propellants used in salbutamol like MDIs, and the Teva generic brand may have a lower impact propellant as well as a brand name product called Aeromir. So if your patient can't use a DPI and they need to use salbutamol like product, there are a couple of options there for you.
Yeah, exactly. I forgot to mention, I've got a little cheat sheet. It's just 3 things to remember, and it's attached to the end of the presentation. And so terbutaline is there, as are a couple other cost effective or sort of equivalent things that are either covered or by pharmacare or covered in some cases. So for people in BC, they might find that helpful.
Okay, that's great. Here's something from a hospital pharmacist. I'm a pharmacist in a hospital setting, and of course, we are all concerned about safety, hence everything is unit dosed. With every dose change, there is enormous waste, the drug, packaging. Also, we have shortened expiry dates so that things are being made more frequently. What are some suggestions for reducing waste in this setting, and what are the policy changes that need to be discussed, and with whom? So,
Yeah, hospitals are challenging. That's why I like talking about this in primary care, because we could just do what we want tomorrow.
yeah,
The policies do need to change on some of that stuff, considering safety and other things. But I think, again, the suggestion you had about, medicines that aren't used, if they're in their little packages and they're safe and nobody's touched them and sneezed on them, we should be able to reuse those. There's nothing stopping us except policy. So that needs to change.
Sure. For the person that posted this comment, if you want to get in touch with me, I have some insight into what Canadian hospitals are doing,
Oh,
what proportion of them recycle unused medications. We have some information locally, but it's interesting because a lot of it has to do with human resources. So, when you talk to individuals, there's a will to reuse these safe medications. Sometimes they're limited by how many people are around to actually do the work. So there's two things I see here. I think one of them is, as I suggested earlier, why do we need pharmacy staff to do it? It doesn't need a skill set to hire other people that are more plentiful. But also, I think there's value in maybe looking at getting a systems engineer to look at why are we sending up so many meds for patients that end up coming back.
Mm.
So,
Yeah.
getting to the root of the problem. So there's all sorts of opportunities in the hospital.
Yeah.
Um, so people are asking for the 4-year references, so we'll make sure that we'll post them on the website, and people have suggested some in the chat. Uh, and so everyone can have access. So here's an interesting question. Dry powder inhalers cost more than meter dose inhalers. Do you think the increased cost to the healthcare system is worth the decreased impact to the environment?
Well, I wouldn't necessarily agree. In some cases they do, in some cases they don't. And so if you look at my cheat sheet, and there's another cheat sheet from Ontario, if anybody's here from Ontario, that's put together by Cascades Canada. But yeah, you can if you choose the right ones, they're not more expensive. They're the same. So.
Yeah,
But I
and
still think it would probably justify the cost when you think of how many other medicines we use we never think about the costs of medicines in most cases, right? People they take what we give them. So yeah, but in this case, there are actually good alternatives.
yeah, I would agree. And it seems like the short-term cost, even if it is higher in terms of acquisition cost, when you factor in all the other layers of paying for the negative impacts on the environment, on health and fisheries and oceans, and
Yeah.
will probably be far greater ahead.
And again, further upstream, just making sure that all those people who are taking puffers actually need them, because a lot of people are treating their anxiety with their salbutamol and other things. People just think they've got asthma, and again, many of them don't. So that's an even better solution.
Just some clarification from pharmacists that pharmacies are not allowed to redispense medications that have been taken by patients and then brought back. But if they're unused and not sent out, then pharmacies can reuse them if they stayed in the dispensary. But if meds are returned to the pharmacy from a patient, they're sent for incineration, which I guess is your point, Ilona, that it's better than flushing them down the toilet.
Yeah.
Someone's posted a link to the city of Ottawa. They publish water treatment data daily, so if anyone's interested.
Do they measure pharmaceutical residues? That's my question for them, because
I don't know.
I don't think.
Yeah. Okay, so here's a question. I have some patients that don't do well with dry powder inhalers for asthma. I continue MDI for some patients to avoid prescribing meds that are not used. One of the respirologists suggested that MDIs are planning on being discontinued. Is this true? As well, don't the patient's inhaler breathe in the substance that can cause greenhouse gases? Have you heard any rumors about phasing
I
out
haven't,
MDIs?
but I wouldn't be surprised, because I mean, a lot of prescribers have heard about this. I'm sure the pharmaceutical companies have heard about it as well. For people who can't, and it's a really good point, we can't switch everybody off meter dose inhalers, but there's also soft mist inhalers, which some people might be able to use even if they can't do the dry powder ones. Yeah, they say they have little tools you can use to check for elderly patients if they've got enough capacity to do the required inhalation. And they say typically preschoolers aren't able to generate enough force to use a dry powder inhaler either. So we're not going to be able to get rid of them completely. Yeah, and there was one more little bit to that question, but I forgot the last part.
Oh, that when you inhale from an MDI, are you inhaling greenhouse gases?
I think most of it, just like with the anesthetic gases, I think most of it ends up in the environment.
Sure.
Sadly. Yeah.
Someone's posted a comment. I wish prescription bottles could be reused. A choice to have new meds in a compostable pouch with a new label. And Tom, my friend and colleague, said that he managed to get his pharmacy to refill a pill bottle last week. So maybe if we all start asking for that, things will change.
Well, I asked one of our local pharmacists, and she said, "Yeah, if you brought a pill bottle in, I'd probably do it." But they said the logistically, it would just get crazy, after a while, having all these empty pill bottles around and having to. But it would probably just be a systems problem. It probably could be done.
Mhm.
The other thing is we could probably, I mean, individuals can, return the pills in a little paper bag, like again, if they're unused, and then peel off the label themselves and recycle the bottles, or reuse them for, I don't know, camping or something.
Sure.
Yeah.
Someone's mentioned that community pharmacies in many provinces can arrange for proper med disposal without charge, and they've given a link. So if any of you are interested in checking to see what's available in your province.
Okay.
So
Yeah,
here's a
I'm under
question.
the impression they had to do that. At least here in BC, I'm pretty sure they have to do it without charge, I
Mhm.
assume.
Yeah,
Yeah.
I believe so. Is incineration actually better environmentally than pills sealed in a bottle going to the landfill?
Yeah, yeah, it's hard to imagine in a way, but that's what they recommend. And again, when you're right, if it's not being flushed, or and if it's just in its bottle, it is a little bit hard to know how that's bad. And I don't know the answer.
Do you know if anything is being done to make DPI inhalers more cost effective for those that are more expensive?
I don't know.
Tom has asked if you're taking new patients.
Yes, no, sorry.
Um, okay, let's see. There's lots of other questions. Yes, City of Ottawa does publish a detailed list of pharmaceutical residues in treated drinking water.
Great.
In BC, switching to dry powder inhalers was fully covered by pharmacare and extended health plans. So that's also good to know. So I guess asking, and I know RX Files has a handy tool to determine if your patient's a good candidate for a DPI or a meter dose inhaler, the weak hands, strong lungs approach. And and we had done a survey of prescribers in the Western provinces about why prescribers pick MDIs or DPIs. And one of the main highest ranked factors was what they just prescribe what they're used to, which makes sense, right? It's how most of us behave.
Yeah.
So I guess having in your mind when you're prescribing a checklist of, is my patient eligible for a DPI, and having that RX files tool handy might be a way to avert some of the problems.
Yeah. I
Here's a,
have a poster up in my office as well, and it came from the Hamilton Family Health team, and and there's another one at Cascades, and it just reminds people to ask us. It just says, "Does your inhaler look like this? Talk to your provider." And so even if I forget, um, yeah, they'll remember. And I have to say, I've been doing this for about a year, and I've hardly had anybody who's not eligible. Like the vast majority of people fall within that age range that I've been able to make the switch if they're
mm,
willing. It's always obviously patient needs to be interested, and yeah.
sure. And I wonder how many patients actually are aware has an impact beyond their health, but to the planet, right? That it would, I would be surprised if most people would say, well, yeah, obviously, just give me the one that
Yeah.
is less polluting.
Yeah, most do, but some are hesitant. They're like, "Oh, I don't know, I'm used to this one," kind of like
Sure,
us, right? We do what we're used to, and
that's right.
some have been a bit hesitant. Yeah.
Yeah. No, I'm not stubborn like that in my old age, Ilona, not at all. Um, Someone saying in Victoria, BC, Community Health Services Home Care had partnered with the Capital Regional District several years back with an initiative to educate the public about medication returns. They had brochures available to all interdisciplinary team members to share with clients at home visits.
Hmm.
So I guess that allied health question earlier on, this could be something that could be revived. This person's saying it was very popular in the beginning, but sort of faded away a little bit since. But um, okay, here's a comment. Mental health centers get long-acting injections from community pharmacies. Many are wasted there's dose changes, automatic dispensing, and clients don't always come in time, so there's accumulation. Sometimes patients admitted to hospital. This just reiterates the waste in the environment and monetary waste, as retail pharmacies cannot take them back. Wish we could do more to prevent this. You know, that's an interesting comment, and right, it reminds me of what we're trying to figure out in the hospital is it's a systems problem. There's something about, and I shouldn't be the one trying to figure it out. I'm not a systems engineer. I'm a mediocre pharmacist at best. So, you know, if we had these outside people that don't, you know, have a different perspective, even in community pharmacies, I think it'd be probably worth the investment. Oh, here's an interesting comment. I've had some patients push back about PPIs because some of them have lactose. How do you respond to them?
I was not aware of that, and I haven't heard that from anyone. So that's interesting. And do they and is there enough lactose? Like if you breathe in lactose, I didn't know that lactose intolerance by the inhaled route would be a thing, but I don't know. Interesting. I might try to look it up.
You had mentioned de-prescribing as one way to reduce the impact, and someone's posted a link to de-prescribing and polypharmacy resources. And we have some great resources in Canada, Choosing Wisely, deprescribing.org. Dr. Wade Thompson, who's a pharmacist that just recently joined the TI, is probably one of the leading experts in this area in Canada. So let me know if you want to get in touch with some of the stuff that he's worked on and with his former group in Ontario. Still does work there. Let's see, I'm looking at the time. We have time for a few more questions. Oh, interesting post about desflurane. It's banned in Scotland. Okay, there's so many questions. Oh, an interesting question. Is it possible to see in the future the environmental effects of medications recommended in clinical practice guidelines? Now, do you have any thoughts on that?
Yeah, I was just talking to somebody about that. Gosh, I don't know where. Anyway, yeah, I'm hoping it's going to become more of a standard thing. I just got out of a 3-day strategy sprint with Interior Health, and we're just talking about embedding environmental sustainability into every single thing we do. So that would be an example, right? And I think we all have to do that. I mean, it's time.
It's time. Yeah, it should have happened yesterday, but
Yeah,
we can start now.
20 years ago.
I know one of my colleagues in the procurement side of PHSA in BC has told me that when they make decisions about which drugs are procured for hospital supply and choosing contracts, that environmental impact is now on their list of considerations, which is great. Someone's talking about incineration. I asked you the question, is incineration actually better? Someone's posted, I know for MDIs, the incineration does decrease the impact versus throwing them out. 4 to 18 kilograms of CO2 equivalent emissions are saved per inhaler with incineration. So there must be something about the heat that does something differently. Case reports of allergies from trace milk protein in lactose-containing inhalers. There's no risk with Bricanyl. There's no risk with Pulmicort. All Respimat versions are fine. Basically, if you look at this post, it's basically saying any inhaler is okay in lactose intolerant patients. All MDIs are fine.
That seems to make sense, really.
Yeah. Okay. Oh, the BC guidelines on asthma, which is in the external review process, has an environmental impact statement on inhaler use, which is great. Just reading through. Okay. I think expired meds are always concerning. Sure, they don't theoretically cause problems, but if we used expired meds and something happens, then we can get the college CMPA to intervene in hand slap. Any thoughts on how to educate people about expired meds and maybe how to avoid so many expired meds in our environment?
Yeah. Yeah, it's a tricky one. A few people have said that, and I don't know if you could. Yeah, I mean, I feel like if it's a non-critical med, I mean, you wouldn't want to tell somebody to not take or to take an old, like a 10-year-old anti-epileptic. But
Hmm.
if I'm telling my patient, if they ask me if it's okay to take their 1-year-old Tylenol, I guess I mean, there's never been a documented adverse reaction, so I think we're safe. You
Hmm.
know, the only concern is potentially slightly decreased potency, and so yeah, for a critical med, I would never recommend it. But for so many of the others, yeah, I don't see how you'd get in trouble.
Hmm.
But again, yeah, I think that has to be something we decide on our own.
Yeah. So there's a comment as you were talking coming in about it's isn't the issue the potency, and I've heard about this lack of potency, but and maybe there is. So maybe we need someone to look and have a list that's curated of here are the ones where potency isn't an issue. Here are the ones where you might, sort of a green light, yellow light, red light list of meds where if it's past the date, don't worry about it. But for the red meds, maybe it's not. Um,
Yeah, I know the U.S. military did this. They've got a shelf life extension program study, and but they didn't actually publish, or at least not that I saw. Maybe you'd have to dig a bit more. Which medications they said, some, are 88% effect, um, potent at whatever many years. But I didn't see a complete list. That'd be interesting to dig a bit further. And
mhm.
I just noticed somebody popped up in the chat, and they mentioned tetracycline, and it reminds me that years ago I did remember hearing somewhere from someone, but I couldn't find it now, that tetracycline was maybe the one exception that actually could become dangerous. I don't know whoever chatted about that, if they know more, and
Yeah,
what that
someone's saying,
reaction was. How bad
yeah,
is it?
yeah. Well, someone's saying that in first or second year pharmacy school we learned about decreasing potency. Maybe we should get those instructors to do a webinar on that. Um,
Probably using the US study.
oh, actually, someone's posted a link, drug expiration dates, and do they mean anything? And saying
Right.
essentially all medications are safe when expired except tetracycline.
I
Um,
wonder what happens with tetracycline.
it's someone's answered. Expired tetracycline has caused Fanconi syndrome, a rare form of kidney damage. So, but that link from Harvard that you posted, thank you for that. And then another comment, and I think we'll call it after this. In 2020, the Capital Regional District in Victoria, through their medications return program, collected over 10,000 kilograms of unused or expired medications, which is probably vastly lower than what's out there, but that's fantastic. And I know we asked the disposal company in the Lower Mainland that collects all the, nurses put medical supplies and meds into buckets and then they get taken away for incineration. In 1 year in the Lower Mainland, it was 300,000 pounds. It was an enormous amount of waste. Not all of that is doses of meds. A lot of it is IV tubing and IV bags and all of that, but there has to be a large number of doses that get wasted. Okay, Ilona, thank you so much. It was enlightening. You've generated so much conversation. Your resources will be useful. Everyone else provided some good resources. So we can't thank you enough. To all of those that attended, thank you so much for sharing an hour with us, and hope to see you again. And wherever you are, have a wonderful rest of your day.